Hello everyone, this is Dr. Vivek Goyal, your nephrology faculty, and today we shall discuss a very important topic from the chapter of glomerular diseases, that is infection related glomerular nephritis. So this term has evolved over the decades, and initially it was known as post-streptococcal glomerular nephritis. It was synonymous. Then it gave way to a new term known as post-infectious glomerular nephritis. But now the most recent terminology is known as infection-related glomerulonephritis. Sir, please explain why has this evolution taken place? Now just see, initially it was believed that it was only the streptococcal infections that preceded a glomerular disease. So it was known as post-streptococcal glomerulonephritis. But it was found and it was researched that only 30 to 50% of patients of infection-related glomerulonephritis had streptococcal infections. That is to say that there were other infections also, like Staphylococcus aureus, maybe gram-negative bacilli also, which were contributing to infection-related glomerular disorders. So it was known as post-infectious glomerulonephritis. So then why did it evolve to IRGN? Because a glomerular disease can not only occur post-infectious, but it can also occur para-infectiously. That is in concordance with the infection together. That is why it was known as infection-related glomerulonephritis. So what is IRGN? It is that glomerulonephritis that occurs para-infectiously or post-infectiously. So a glomerular disorder that can occur as a para-infectious disorder or a post-infectious disorder is known as IRGN, and this is how the evolution of the terminologies have taken place. And today the most standard international term is IRGN and not PIGN or PSGN, but we do use it colloquially sometimes. Now, what are the mechanisms of several infections causing glomerular diseases? First and foremost, they cause circulating immune complexes. That is streptococcal itself. And the evidence is that there are antibodies against the streptococcal pyrotoxin exotoxin B and the nephritis associated plasminogen receptor. Now, it can also form in situ immune complex. That is, apart from circulating immune complex, there could be in situ immune complex again caused by streptococcus, and because there are subepithelial deposits in the PSGN and you can identify the exotoxin there too. Also, there could be antigen deposition straight away with complement activation, which also occurs in streptococcal infections. So streptococcal can cause circulating immune complexes, it can cause in situ immune complex, or it can cause antigen deposition and then complement activation. Apart from this, how does Staphylococcus work? Usually, it acts as a super antigen that binds to the dendritic cell, the antigen presenting cell, and activates the T cell and polyclonal B cells and induces a lot of polyclonal immunoglobulin production. This is how Staph aureus acts. Apart from these, now there are certain viruses which are directly toxic to the renal tubular epithelium or the renal glomeruli or the kidney itself, and they are the HIV and the parvovirus, because you can even identify the HIV virus in the podocytes. Apart from this, there could even be a direct renal cell injury, what happens in hepatitis B, or there could be a cryoglobulin production as occurs in hepatitis C. So there can be a host of mechanisms how infections involve the kidney and especially the glomeruli. So it could be through immune complex, either circulating or in situ. It could be via super antigen binding, or it could be a direct invasion. Now, when we talk about IRGN, especially bacterial IRGN, see, IRGN could be caused by bacteria, it could be caused by viruses, or it could be caused by parasites. But when I'm talking about bacterial IRGN, of course, the first and foremost, which we have been studying from, say, second year pathology from the Robbins textbook of pathology is post-streptococcal glomerulonephritis. But just mere knowing PSGN is not sufficient at this level. So what we have been trying to do is, let us study, as we always do, a comparison of the different bacterial related IRGNs. So coming to post-streptococcal glomerulonephritis, shunt nephritis, endocarditis related glomerulonephritis, or an IgA dominant IRGN, where it is an IRGN which is predominantly having an IgA on the immunofluorescence. Very, very important. Coming to what is the predisposing factor of IRGN? Of course, the predisposing factor are the poor sanitary conditions and of course the low socioeconomic class. Of course, needless to say that PSGN mostly occurs in the underdeveloped and the low economic countries. Coming to shunt nephritis, what do you require for shunt nephritis to occur? You don't require anything, but you require a shunt. And what shunt is that, sir? Sir, it could be a ventriculoperitoneal shunt, which all of us know. It could be a ventriculoatrial shunt also. Sir, which shunt is more associated with IRGN? Of course, ventriculoperitoneal shunt has the least association with IRGN, and ventriculoatrial shunt is the most common association with IRGN. So most commonly, which shunt causes glomerulonephritis? Answer is ventriculoatrial and not ventriculoperitoneal. Please keep this in mind. Coming to endocarditis, sir, what predisposing factor? Of course, you need either a rheumatic heart disease, a structural heart disease, or it could be an IV drug abuser. All those which you require for infective endocarditis. Coming to IgA dominant IRGN, sir, whom is it more common in? It is more common in diabetics. It is more common in immunocompromised like HIV or even transplant recipients. If I talk about epidemiology, see, post-streptococcal glomerulonephritis is of course most common in children, usually under 10 years of age. But sir, it cannot occur beyond in adults? No sir, it can occur. It is more common in children, but it can occur in adults also, though a very less frequency. Coming to shunt nephritis, sir, whom does it occur in? Again, it is more common in children and in the young population. Endocarditis related GN is more common in the young middle-aged, though it can actually occur at any age. What about IRGN? Sir, IRGN occurs more commonly in the elderly. Most patients of IRGN are elderly diabetics more than 60 years of age. Very, very important. Coming to the cause behind post-streptococcal glomerulonephritis. So you do know it is definitely a post-streptococcal glomerulonephritis. So it is a group A streptococci. It is a group A streptococci. Of course you know that. Now that group A streptococci, is it only that? No sir. It can be caused by group B or group G streptococci. But of course it is very, very less common. Coming to shunt nephritis. The most common cause of shunt nephritis is none other than staph epidermidis. What about endocarditis related glomerulonephritis? Again, the most common cause is staph aureus, and as the name implies, it is an IgA dominant IRGN. Here also the most common cause is staph aureus. Now some people even like to call it Staphylococcus aureus associated glomerulonephritis. It is a SAG, but a SAG of nephrology, not of hepatology. Please remember that. But that is not an international term. Better stick to IgA dominant IRGN. So now we have understood the most important causes. Now what about the history what is the preceding history of post-streptococcal glomerular nephritis? Sir, it is usually a pharyngitis, or sir, it is a skin infection or an impetigo that precedes a PSGN. Pharyngitis precedes by 1 to 3 weeks. Impetigo precedes by 2 to 6 weeks. And it causes PSGN. Now, sir, my question is, sir, we had studied in microbiology that there were certain serotypes of the M serotype, basically, of streptococcal group A that more commonly cause pharyngitis. Which were they? They were M type 1, 3, 4, 25, 49. What about which serotypes more caused impetigo and then led to PSGN? They were type 2, 49, 55 and 60. So sir, what is the moral of the story? The moral of the story is 49 is common in both. So if I ask you a very, very difficult MCQ, which streptococcal AM type causes both pharyngitis and impetigo leading to PSGN, answer is 49. Answer is 49. Now coming to the preceding history of shunt nephritis. So what do I require, sir? I require a shunt. Sir, how much time usually after a shunt insertion can PSGN takes place? PSGN can occur months or years after shunt placement. Sorry, not PSGN, it is the IRGN. So IRGN can occur months or years after a ventriculo-atrial, most commonly, less commonly a ventriculo-peritoneal shunt. Now what do I require for an endocarditis rated GN? I require what? I require valve vegetations. What else? What do I require for an IgA dominant IRGN? I require a staph infection. That infection could be in the blood. It could be a sepsis. It could be a soft tissue infection. It could be a pneumonia. It could be an osteomyelitis and so on. Anywhere a focus of Staphylococcus aureus infection, and then it creates the superantigen and so on, and whatever we have studied so far. Coming to systemic features. Now, how does post-streptococcal glomerular nephritis present to you systemically? Systemically does not have much. It could only have the evidence of pharyngitis or the skin infection, whichever I have told you. So nothing much to be discussed, much of it. What about shunt nephritis? Sir, if it is an infection of the shunt, I mean, you will have fever. You will have very commonly raised intracranial tension. Very, very important. And it is accompanied by hypertension also. What about endocarditis related? See, we all know endocarditis related systemic symptoms. So there will be fever, there will be new onset murmurs, there will be splenomegaly, there will be skin lesions in the form of Janvey lesions, and you will have some retinal lesions. You all know it, not going into the details. What about IgA dominant IRGN? Again, I shall have evidence of systemic infections. So I can even have a boil, I can have pneumonia, I can have high spiking fever, and so on. Coming to the renal manifestations. How does PSGN present to you renally to a nephrologist? And yes, the classic presentation of PSGN is acute nephritic syndrome. So what is acute nephritic syndrome? We all know it is characterized by hematuria, hypertension, oliguria, and plus minus edema. So there is hypertension, there is oliguria, there is hematuria, there could be edema as well, and of course on tests you will find proteinuria. What about shunt nephritis? How does shunt nephritis present to you? So shunt nephritis will present to you with microscopic hematuria. There will be proteinuria, and there will be a fall in GFR, but that fall in GFR will not be that acute, which happens in acute nephritic syndrome. How does an endocarditis related glomerular nephritis present to you? Now, this can present to you, in fact, both of them can present to you with a rapidly progressive renal failure. So both of them can present to you with a deteriorating kidney function over days to weeks. And what do you get here? Again, you will also get here microscopic hematuria and of course proteinuria. It could even be sometimes nephrotic range proteinuria in IgA dominant IRG. So this is how they present to you, present to a nephrologist. Coming to infection markers. So how do we think that it is a shunt related nephritis or it is an endocarditis related nephritis? So how do you diagnose a PSGN? Of course, you can have a throat infection or a skin infection culture, and you could grow a group of streptococcus, or more commonly you get some other investigation markers which are very, very important here, like the ASO titer. You get the anti-DNase B. You could even get a streptozyme panel done. Now, what is streptozyme panel? Streptozyme panel is A plus B plus anti-hyaluronidase and anti-streptokinase. So these are all serological markers which you can get in the serum of the patient, and you can indirectly prove that it was a streptococcal who caused the infection. Now, streptozyme panel is again quite sensitive because the ASO titer is elevated in usually around 65% patients, the anti-DNase B in around 70% patients, and streptozyme panel is quite sensitive compared to the above because it's a combination of four things. It is a combination of ASO titer, anti-DNase B, anti-hyaluronidase and anti-streptokinase. Coming to shunt nephritis, what can I get here? What I can do here is I can go for a CSF culture or a shunt tip culture because I will have to ultimately take out the shunt. In endocarditis, of course, you have to go for the paired blood culture, and you all have studied in medicine and cardiology as to what is the process and protocol of drawing blood culture from a patient of suspected infective endocarditis. Coming to IgA dominant IRGN, again you have to go for say a blood culture or a tissue culture, whichever tissue you may think of. It could be sputum, it could be synovial fluid, it could be anything. It could be a pus from any tissue, wherever you could go grow Staph aureus. Now coming to other immunological markers. Now see, what about C3's complement levels in these? You do know that C3 level is low in PSGN because it's a disorder of alternate complement pathway, whereas C4 is normal. Shunt nephritis, both can be low. In endocarditis, both can be low. In IgA dominant IRGN, only C3 is low, whereas C4 is normal. Very, very important. Coming to immunoglobulin, in PSGN, you could get an increase in IgG or IgM. Here you don't get anything. Whereas in IgA dominant IRGN, just like IgA nephropathy, you could get an increase in IgA. Whereas other markers in shunt nephritis and endocarditis related GN, you could get a rheumatoid factor positivity. You could even get evidence of cryoglobulins. What about post-streptococcal glomerulonephritis? What about PSGN? Is there something, an immunological marker, which is very sensitive and very specific? Yes, sir, there is one. You could demonstrate antibody to streptococcal pyrogenic exotoxin B and nephritis associated plasminogen receptor. So what is that? It is streptococcal pyrogenic exotoxin B and nephritis associated plasminogen receptor. Why do I tell you this? Because if an MCQ comes, which is the most sensitive and specific serum marker to diagnose a preceding streptococcal infection in a case of glomerular nephritis, answer is this. It is even more sensitive and specific than streptozyme panel. It is most sensitive and specific. So it is very, very important. It has never been asked in an MCQ yet because it's a very latest information. So you need to know this as well. So this is a very, very important diagnostic workup of these 4 infection-related glomerular nephritis. Now coming to the biopsy finding of each. Now, how do you and what do you get on biopsy of each? Now, in post-streptococcal glomerular nephritis, you classically get what is known as diffuse proliferative glomerulonephritis or DPGN. What do you mean by diffuse proliferative? Sir, there is proliferation of endocapillary cells, proliferation of mesangial cells, and there is proliferation of leukocytes. So there is diffuse proliferation of all the cells of the endocapillary proliferation, there is mesangial proliferation, and there is infiltration of leukocytes, and there is a accentuated increased lobular size of the glomeruli, which is known as DPGN. What about shunt nephritis? Now shunt nephritis on light microscopy most commonly has a membranoproliferative pattern, which is known as MPGN, membranoproliferative glomerulonephritis. Coming to endocarditis related glomerulonephritis, it is usually the most common pattern here is a RPGN or a crescentic glomerulonephritis. Talking about IgA dominant IRGN, there is usually endocapillary proliferation with leukocytic infiltration. So it is quite a bit like between PS gene and even IgA nephropathy. So there is endocapillary proliferation, but there is also invasion of leukocytes. There is inflammatory cell proliferation. Now, what will you get in PSGN immunofluorescence? What do you get here? You get a typical garland pattern or a starry sky pattern in active glomerulonephritis, and you can get a mesangial pattern in a resolving PSGN. So this is an acute stage, this is a resolving phase. So on immunofluorescence, you get a typical MCQ, that is starry sky pattern on immunofluorescence is seen in which disease? Answer is post-streptococcal glomerulonephritis, that too in the active stage. Now basically what does it mean? What do you get here? What you get here is you get C3 dominant deposition plus IgA, IgG or IgM. What about shunt nephritis? Here you get IgM or IgG plus C3. Even in endocarditis related GN, also you get almost the same thing. But what about IgA dominant IRGN? As the name implies, here there is definitely IgA, C3, and which light chain is deposited here? Answer is kappa light chain is deposited more than lambda. And here, because in IgA nephropathy we know IgA is dominant there, but here it is the C3 which is dominant, and IgA is either less dominant than C3 or it is co-dominant. Please understand this. So it is a C3 dominant with IgA deposition and kappa more than lambda deposition in terms of light chains. So it is basically a C3 dominant immunofluorescence that we see in most of the things. But a very important MCQ, that is starry sky Garland pattern in PSGN. Coming to electron microscopy, what do you get here? Yes, just remember what was written in Robbins. You get a lumpy, bumpy deposit. So you get a subepithelial humps plus subendothelial lumps on electron microscopy. Coming to shunt nephritis, because it's an MPGN pattern, here you predominantly get subendothelial deposits. Here you get subendothelial deposits. Whereas in these two, you get mesangial deposits, subepithelial or plus minus subendothelial deposits. I hope it is clear. So it is more commonly asked about the finding of PSGN, and most important finding is this: the subepithelial humps. So you get a lumpy, bumpy deposit in PSGN, and likewise you can get in other also, which I have told you. This is the microscopic finding of these four important IRGN disorders. Now, what is the treatment of each and what is the prognosis of each? Now, how do you treat PSGN? Do you give steroids? Yes, you give steroids. If you say so, it is the most commonly given wrong answer. Sir, there is no scope of steroids. Please write it and cut it. You do not give steroids in PSGN. Only treatment is supportive therapy. Just give support, nothing else. Sir, antibiotics? Yes, antibiotics can be given if there is evidence of infection. What about shunt nephritis? So first and foremost, remove the shunt, and yes, antibiotics. What about endocarditis related glomerulonephritis? Yes, of course, IV antibiotics. And so also in IgA dominant IRGN, you have to give nothing but antibiotics, and mostly it's a blanket rule that you do not have any role for steroids or immunosuppressants unless it's an RPGN type of a presentation. I hope I'm clear. So just let me write here, if RPGN or crescents are there, only then you give steroids. Only then is there a role of immunosuppression and immunomodulation. What about the prognosis? The prognosis of PSGN is very good, more than 90% chances of recovery. Coming to shunt nephritis, the prognosis is moderate. In 50 to 60% patients, after removal of the shunt, the patients improve. In around 20-30% patients, they have partial recovery, and in less than 10% of patients, there can be progression of kidney disease. Coming to endocarditis related GN, the prognosis is bad, whereas the worst prognosis is IgA dominant IRGN. So these are the very, very important MCQ points from these four bacterial infection related glomerulonephritis. But PSGN, it is very, very important to know in toto, no matter how much you know. We have discussed about the different M serotypes, we've discussed about the clinical features, we've discussed about the different findings as well as how to treat it. But what are the poor prognostic factors in a case of PSGN? Number one, adult age, because in adults the recovery rate is less. Number one, there can be some atypical presentations, like there can be congestive heart failure, there can even be hypertensive encephalopathy. So in adults it is not a good prognostic factor. Number two, if there is nephrotic proteinuria, so if there is excess proteinuria more than 3.5 grams a day, it denotes marked injury to the filtration barrier. So it is not a good prognostic factor. Number three, a crescentic presentation. So if more than 50% of the glomeruli have crescents, that is known as a crescentic GN, it carries a very poor prognosis. It is usually not present in children, usually a atypical feature which is more present in adults. And last but not the least, if there is a complement dysregulation, that is, what do I mean by this? Usually the C3 normalizes by 4 to 6 weeks. If C3 does not normalize by 6 weeks, it may be harboring a C3 glomerulopathy. So you know, a C3, a persistent hypocomplementemia beyond 6 weeks in a case of PSGN, whom you were treating as PSGN, you have to suspect a C3 glomerulopathy and then you have to do a biopsy. Now, when do you go for a biopsy in a PSGN? Say if a young patient comes to you with a typical acute nephritic syndrome, will you biopsy him or her? Of course no. There have to be certain atypical presentations. So if there is a rapid rise in serum creatinine, so you're suspecting maybe a crescentic variant, or maybe you're suspecting something else. Number two, when do you biopsy the patient? Number two, if there is a persistent low C3, so there's a persistent rise in serum creatinine, or there's a persistent low hypocomplementemia beyond 6 to 8 weeks. And last but not the least, if there is a recurrent hematuria in the patient. So you know, you have to suspect, are you missing out on IgA nephropathy? Is it something else that you're missing out on? So if there is a rapid rise in serum creatinine, if there is persistent low C3, or if there is recurrent hematuria in a patient, which is unlikely in post-streptococcal glomerular nephritis, answer is go for a biopsy. Go for a kidney biopsy. So with this, we come to the end of the important bacteria-related IRGN, and we have also discussed the very important post-streptococcal glomerular nephritis in this module as well. Now, after the bacteria-associated infection-related glomerular nephritis, coming to important viruses that cause glomerular nephritis. And of course, if we talk about virus-associated IRGN, of course, we cannot forget the hepatitis viruses. So, you know, there are three important hepatitis viruses, that is hepatitis A, hepatitis B, and hepatitis C, out of which hepatitis A is usually not associated with glomerular nephritis. Now, talking about hepatitis B and hepatitis C, these are two important viruses. Now, in hepatitis B, The most common glomerulonephritis associated with Hep B is membranous nephropathy. So hepatitis B can be associated with membranous nephropathy, and secondly, it can be associated with a membranoproliferative glomerulonephritis. It can even be associated with what is known as polyarteritis nodosa, which of course is not a glomerulonephritis, mind you. It is not a glomerulonephritis. It is basically renal involvement, so to say. So most common is membranous nephropathy. Second most common is membranoproliferative glomerulonephritis. You know, membranous nephropathy usually presents to you with a nephrotic syndrome, whereas MPGN can be a nephrotic presentation, including both of them. Now, talking about how do you treat, of course, now if there is evidence of active hepatitis B replication, so if active Hep B replication present, you have to give the patient antiviral therapy. And what do you give nowadays? You give the standard entecavir therapy. Of course, in the presence of active viral replication, no role of steroid or immunosuppressive therapy, because they can even flare up the hepatitis B replication. Very, very important. Now coming to hepatitis C associated glomerulonephritis. Now the most common renal lesion in hepatitis B, just the roles are reversed here. It is MPGN and not membranous. It can cause MPGN. It can even cause membranous nephropathy, but it is of course not that common as MPGN. Now MPGN is the most common. Now what is the presentation of MPGN? Again, it is like membranous nephropathy presents to you with a nephrotic syndrome, whereas MPGN can present a nephrotic syndrome. So there is hematuria, increased blood pressure, as well as heavy proteinuria in the form of nephrotic proteinuria. So it is an overlapping presentation. Now if you go for a complement levels, it is low in MPGN, whereas it is normal in membranous nephropathy, which is associated with hepatitis C. What else? Very, very important is cryoglobulins. Cryoglobulins are often present here. It is negative here. It is negative here. How do you, like hepatitis C can present to you with both an pure MPGN or an MPGN with cryoglobulinemia. So usually cryoglobulinemia is associated with skin lesions. There can be palpable purpura. There can even be livido reticularis. There could even be gangrenes due to cryoglobulinemia. We have seen even gangrenes due to cryoglobulinemia. So this is how, hepatitis C associated glomerulonephritis presents to you. And of course, how do you treat them? It is of course the same. You have to give the patient antiviral therapy. But if the patient has a cryoglobulinemia, if the cryocrit is more than 5%, you may even have to go for a plasma exchange if the cryocrit is more than 5%. Very important. Now, after viral infections causing IRGN, of course, we cannot forget malaria. Now, you do know the most common, prevalent is obviously Plasmodium vivax, but it usually does not cause glomerulonephritis. Coming to Plasmodium falciparum, it can cause, and usually it causes, a mesangioproliferative Mind you, mesangial-proliferative is not MPGN. I have told you previously. So it's usually causes a mesangial-proliferative glomerulonephritis. And most important from MCQ point of view, which usually don't get to see in our country, is Plasmodium malariae. And what does it cause? It causes something which is known as quartan malarial nephropathy. Because Plasmodium malariae is also known as quartan malaria, because it causes fever every 4th day. You do know that. So let me tell you something important MCQs about quartan malarial nephropathy. First and foremost, it is also known as tropical nephritis. Now, it is how is it caused by? As I told you, it is caused by repeated and chronic infection by Plasmodium malariae in the endemic zones. So it is not an acute infection associated glomerulonephritis like Plasmodium falciparum. It is a repeated or a chronic infection due to Plasmodium malariae. Now, how does it present to you? How does it present to you? It presents to me like a nephrotic syndrome. Like a nephrotic syndrome, which is usually a steroid resistant nephrotic syndrome. Now, what will I get in biopsy? In the biopsy, what I get is a focal segmental glomerulosclerosis lesion. I get an FSGS. And how do I treat it? Do I give steroid to this patient? How do I treat quartan malarial nephropathy or tropical nephritis? I only give anti-parasitic therapy or anti-malarial therapy, and I try to eradicate the agent from the body. There is no role of steroids, which is very, very important. So in an endemic zone, you always have to take the history of quartan malarial nephropathy. Otherwise, you would have gone treating the patient with steroid and immunosuppressants, and it wouldn't act. So the only treatment is anti-parasitic therapy. But please remember that it is not a good prognostic disease. It is a progressive, irreversible disease. Even the anti-parasitic agents don't act completely. So it is a progressive, irreversible. Very, very important. So this is it about the important MCQs from the infection related glomerulonephritis. Thank you. Hope you enjoyed watching.